Okay. All right. So thank you very much, Eric, for the opportunity to come out and give this presentation. Larry and I are delighted to be here. Just by way of a quick introduction, I'm Linda Laskowski Jones. I am an advanced practice nurse. I've been a nurse for more than 40 years, so a long time, all in emergency and trauma care. I'm also a member of the Ski Patrol at Blue Mountain and Pennsylvania EMT. Uh, Larry and I met in the back of an ambulance many, many years ago. We've been married, like coming up on 37 years now, and we love wilderness medicine. Both of us hold fellowships in wilderness medicine. So we're going to talk about wilderness tonight. So Larry, you going to introduce yourself?
Larry Jones, as Linda said, we met at the University of Delaware. With the University of Delaware has a student-run ambulance called the University of Delaware Emergency Care Unit. Met there many years ago, and I've been a ski patroller and an EMT in some form for about 7 years, something like that. So
Yeah.
really enjoy doing this, and hope everybody has a good time and maybe even learn something.
So, absolutely. So our goal tonight is just to talk about the wilderness and give you some more information than what you would typically get if you're on the ski patrol, than what you would get at a refresher, and certainly more than the average EMT course. Uh, and not only just information about the wilderness, but it's about what to do, particularly if you don't have the resources maybe immediately available to you. How can you improvise? And also how you can keep yourself and others safe, because not getting into the situation in the first place is the goal. So we hope you enjoyed this program, and by all means, if you have questions, we look forward to those questions and discussion around some of these topics. So without further ado, let me see if I can advance this slide. My slide does not want to advance. Let me see if there's another strategy. Okay, so we have no financial relationships associated with this presentation. And I mentioned the objectives, but just to recognize those settings and situations that are high risk for outdoor emergencies, and how to manage common outdoor emergencies based on care priorities. So I'd like to stop. I'm seeing the stop share on my screen, and it's affecting me apparently. I'd like to start with lightning and give you kind of an in-depth view of lightning, because it is a very important risk in the outdoors. And I'm going to start with a few myths and legends. So lightning's been feared and revered from ancient times. And people used to believe that the gods were using lightning as a weapon. You can imagine the picture of Zeus or Jupiter hurling lightning bolts. The areas that were struck were frequently thought of as sacred areas. And there are still myths today. And in fact, although this is more modern day, it's certainly not totally modern day. This article appeared in Newsweek in 1999. It is a tragic case of pure act of God. London coroner Dr. Paul Knappman, in a report on the deaths of two Thai women struck by lightning in Hyde Park 2 months ago due to metal underwires in their bras that conducted an electrical charge to their hearts. No, probably not. So, so what do we know about lightning? So it is a year-round phenomenon. It is worldwide. You usually have lightning storms in the afternoon and evening hours, and lightning is associated with these cumulonimbus clouds, which I have a picture of below. And when you look at the map of the world, you will see that the strikes are sort of identified in that red and orange color, and that the highest number of strikes are in Central Africa. For the United States, when we look at fatalities, there are two states that predominate in fatalities, and they are Florida and Texas. However, when you adjust for the population in those states, Florida still is very high, but Texas kind of falls back a bit. However, when you look at some other states, you'll see Colorado, You will see, Utah and some of the western states where oftentimes, we go for our mountain travel and just recreation. Be aware that when you're there, lightning is a risk, and we're going to talk about why that is indeed the case. We also know that snow blizzards can be associated with actual lightning storms. I know I've been at the ski area Blue in some blizzards where it's lightning. And lightning in the winter is just as dangerous as it is in the summertime. So for people who are on chairlifts, lightning will pose a risk to them. And I know in the case that I can think of very vividly, we had to get everyone off the chairlift and then get everybody to shelter, just like you would in a summer lightning storm.
When you're hanging from a metal cable on a chairlift and you hear thunder snow, you're not likely to get quite as excited as Jim Cantori does on the Weather Channel when he hears it jumping up and down. You want off that chair.
Absolutely. So, having the skis on and, you've got metal all around you and you're at a high point, that is not a safe place to be. So more about lightning. So what happens in terms of the anatomy of a lightning strike? So lightning is a series of negative charges that are coming down from above. And the ground is positively charged, and the ground is pushing up these positive charges. And what happens is this channel forms. And so as the negative charges come down and the positive charges go up, a uh, shock wave will occur as that strike goes back up the channel that's formed. And that is what actually creates thunder that you hear. So when we look at the types of lightning, there are several forms. There is the cloud to ground lightning, and of course, that would be the most dangerous. There is intercloud, which is from one cloud to another cloud, and there is intracloud, which is the most frequent, and you can just see the clouds sort of lighting up. It is a very frequently occurring phenomenon, occurring more than 50 times per second around the world. And this current is not AC or DC. It is a current phenomenon. It is more like pure plasma energy. And so it behaves in different ways than your electrical outlets or even the DC current that you would get in a defibrillator. So the stroke diameter is, you would think, it's kind of small, 2 centimeters to 3 centimeters. But when you look at the temperature of that stroke, so 8,000 to 50,000 degrees centigrade, and 10 to 20, or excuse me, 10 to 200 million volts, that is a very hot and a very powerful a stroke that is coming down. So it's important for EMS, for patrol, anyone who is doing a coverage in any type of event, event medicine, to see and understand the environmental evidence of lightning. So the picture that was taken, I believe, by Larry of our
Mhm.
neighbor's front yard after a lightning storm where their tree was struck. And you can see the bark has just peeled off that tree, and there are branches and leaves all around the ground. So that would be one area of evidence that lightning struck. And then the other is actually of a golf course. And you can see that the ground was struck. And when we look at what happens to the skin after a lightning strike, you're going to see that the pattern on the skin is very similar to the pattern that you would see on the ground. It's a very interesting phenomenon. So thinking about why this might be important to know. So you're called as an EMS provider and you have a person who is found down. So you want to look around because it may not always be obvious that lightning struck this individual. You don't know why they're down. When you start looking around and you start to see the environmental evidence, you can start to put the picture together. So when we look at victims, the victims are the same people who are involved in the trauma. More than 80% are male because they're the ones who don't see the need to come in from the thunderstorm. 41% are in that young 15 to 34 age range. And really interestingly, 12% of these lightning strikes occur to people who are indoors. And people can be struck if they're standing in front of an open window or one that just has a screen, if they're standing close to a fireplace, if they are on a corded telephone, because the strike can actually come through the telephone lines coming into the house and actually affect the person. And literally, it's a blast effect while the person is on the telephone. It won't happen with a cell phone, clearly. Uh, People have been struck in their shower, in their tub, in front of their sink, and they have also been struck while sitting on the john. So I have a picture, and it's not one that I know the source, so I can't actually use it in the presentation, but it was a toilet that had exploded as the lightning strike came down through the indoor plumbing. It must have been metal plumbing, literally blew the toilet apart and blew the guy right off the toilet. So I'm sure there's an ICD-10 for that, but not an experience that, you would expect. And I can only imagine the guy did survive, but I can only imagine he's explaining what happened to him and why he's in the hospital.
We do know a gentleman, he's a physician in the wilderness medicine community. He's been struck twice in his car. And in one case, he was driving out west, apparently not a cloud in the sky. He had the windows down, and a lightning strike came through his driver's side open window and struck his wife in the passenger seat. She did survive, but she was struck. So and there was no storm in the area.
And in that particular case, I believe it also blew out his electrical
Oh yeah,
system in his
yeah.
car. Yeah. So strange things can happen. Most of the fatal strikes they're simultaneous, with the peak thunderstorm activity, which is typically in June and August, and usually between 12 noon and the early evening hours. Even though you have this great magnitude of energy, the mortality rate for a lightning strike is actually on the lower side. So 1 out of 10 people will die. If you're 1 out of 10, well, that's a pretty high proportion. However, you think about that energy and there's reasons for this, and we're going to talk about that. So your lifetime risk of a fatal lightning strike is about 1 to 10,000. However, you can put yourself at greater risk by doing some things that we'll talk about that can put you at higher risk. So every year there's about 30 deaths from lightning in the US, and that's on average, and that has been pretty consistent between 2008 and 2018. The number is somewhat declining as people are becoming more aware of lightning prevention strategies. However, in the world, across in terms of worldwide deaths, it's estimated that there are 24,000 people who are killed by lightning every year, with about 240,000 injuries. So this is a big problem, and it's especially prevalent in areas that are wide open and have no shelter. So your highest risk locations, you can see that big open area. People who are on water, so people who are in boats, who are standing in water, who are swimming, high points, particularly mountaintops and ridge lines.
Let's do non-English place names for 800. Answer.
Hey there, Joe. Anyway, so if you are also standing near an isolated tree or a tall object, lightning will tend to strike the tallest object in the area, and that lightning can come down and it can side flash off of that object or tree. So, and I'll show you some direct ways that that can happen. So the deaths and injuries, when you look at when and where this happens, the highest risk activities are sport activities that are, of course, outdoor, camping, hiking, boating, and fishing. And there is literally no safe place in a thunderstorm except if you are in a fully enclosed area, and that includes having the windows closed. So this is a slide off of NOAA, National Oceanic Atmospheric Administration, showing that water-related lightning strikes and fatalities are highest, actually. And then you can see sports, which can include things like golf. You know, you typically classically hear about golf as being a high-risk activity in a lightning storm, and camping, and then, of course, other types of activities after that. So how does lightning cause a fatality? So a person's walking along and literally the bolt from the blue, the direct strike, it comes from the cloud to the ground and that's it, right? So, but that's actually a relatively small number of fatalities, the 3 to 5%. But it does certainly give you a clear picture of how this happens. 20 to 30% of the fatalities are due to the side flasher or side splash type of mechanism. And you can see that the lightning comes down, it hits the tree, and then the lightning splashes off the tree onto the individual and takes them down. So here is one of the highest ways of becoming a lightning fatality is something called ground current. And what happens is that the lightning bolt comes down through the tree and then it runs along the ground. Those negative charges are running along the ground, and guys walking on the ground, and it just takes them down. That's also known as step voltage. Step voltage. Conduction is the other way. So in this case, the guy is holding on to the fence. The lightning strikes the tree is in contact with the fence, which is metal, and then down the guy goes. And that's 15 to 20% of the fatalities.
This would also include the folks that are on a landline telephone when their house gets struck by lightning, or they're in a shower when the house gets struck by lightning and the electrical charge travels through the water pipes and through the water.
Here is a picture. This is a pretty common picture that you find. This is not the only time this has happened, but the cattle were all in contact with a metal fence at the time of the lightning strike of the fence, and it killed all of them. So this is a really significant way of producing a lightning fatality. And then there's also the upward streamer, the positive upward streamer. So in this case, the lightning bolt comes down the normal way, hits the trees, and when that lightning bolt comes down, keep in mind you've got these positive charges on the ground, which are trying to come up and join that downward streamer. So you've got the downward streamer coming, and then you have the upward streamer trying to meet it. And it can be in a variety of places. There may be more than one, but this one came up where the guy was standing, and out he goes. And there's another 10 to 15% of fatalities. So people don't often think about the fact that you're literally struck by a streamer coming up from the ground. So what happens when you're struck? So if you are wet, water will conduct the electricity, and if you're struck, any wetness on your body will just vaporize into steam, and this flashover effect occurs because that lightning strike is this very rapid millisecond type of situation. But the flashover produces a blast effect. And that blast effect can damage the clothing, and it can literally blow the clothing right off the person. It can throw the patient. So they may wind up also having a traumatic injury as a result. And you can see a situation like this. So this was a news story. An Atlanta man blown out of his boots by lightning, happy to be alive. ABC News, this was in 2014. Someone got this picture when his boots were literally still steaming from that superheated blast effect. You can see the weather fatalities from 2024. The circled area there would be lightning fatalities. So it's actually rather low in the grand scheme of other types of weather fatalities. So for example, you have heat as being the #1 cause of deaths from weather, and flood being the second highest. Lightning is in there. However, it's not as significant, and the reason why most people survive is because of this instantaneous duration of contact. It's a flashover, and so that is what keeps mortality low. And there's also a way to resuscitate people who are struck if you can get to them right away, which we will discuss. So there's the direct way of being a victim of lightning, and that is from the electricity itself, right? That current phenomenon that flashes over you. And it depends again on how that happens, and you saw those different ways that lightning can strike. But there's also heat. So typically, burn injury in lightning is not a significant problem. But there are things that can superheat that can actually produce an injury that needs to be managed. It's just not one of the high priority injuries, considering the other things that may be going on. And then, of course, that concussive force or blast force, which can be a major mechanism of injury that produces trauma. But there's indirect effects as well. And those indirect effects would be, for example, forest fires and building fires from the lightning, explosions, as well as falling objects. Like you happen to be under the tree, you're camping, you've got your tent set up, and there's a thunderstorm going on. What if lightning strikes the tree that is right over your tent, or blows branches, heavy branches, at your hiking area, your tent, whatever you have out there, and you're injured from that. So in terms of the pathophysiologic effects of lightning, this is the most important part of this presentation from the standpoint of caring for the individual. You have to recognize that when you have that flashover, it's like one big DC counter shock that can occur from maybe getting defibrillated. It's like the lightning is defibrillating you, and it can actually produce a systole or ventricular fibrillation, but you have no effective heart rate, right? So you're in cardiac arrest. Now, the nice thing about cardiac cells is that they are autorhythmic, meaning if given the right oxygen and nutrients, those cells will actually start beating again. But the problem is that in that flashover, there may be damage to that medullary respiratory center, which is what is giving you the ability to breathe. So if that medullary respiratory center is involved, you then have apnea. You have your diaphragm is paralyzed. You don't breathe, and you have no brain ability to stimulate that respiration. So the heart may come back, but if you're not breathing to supply the oxygen, you go into a secondary hypoxic cardiac arrest. And you can have direct pulmonary injury, which could be contusion and hemorrhage. And you can have all manner of cardiac conduction abnormalities, and different types of dysrhythmias and ischemic changes. And not all of these are immediately apparent. Sometimes these changes aren't appreciated until the second day after a lightning strike. There are also central nervous system effects. There can be brain injury, intracranial hemorrhage, something known as coagulation necrosis, which literally is just like coagulating the blood that is in your brain, so that it's kind of like one big clot. You can have post-concussive syndrome and cognitive defects. And there's this really interesting phenomenon, and we have had lightning victims come in to the emergency department where I worked. They have something known as a coronoparalysis. Now, the word corono literally means lightning. So it's a lightning paralysis. And in that case, the muscles are stunned, but also the blood vessels are stunned as well, and they may be very, very tight. So if you're looking at this patient, what you see is this patient who can't move, or they move minimally, and their skin is very, very pale. It looks like they're not getting any blood flow to their extremities. It is that intense vasospasm. And they also can have hypertension as a result of this because of this massive amount of vasospasm throughout the body. So this can resolve rather quickly, but sometimes it can take hours. And the bottom line is it typically does resolve. People in the meantime need reassurance that they are not permanently paralyzed, as long as there's no neck trauma that might also be a causative factor. Typically, this is going to involve the lower limbs greater than the upper limbs, and just over time, the blood vessels start to work normally again, and the muscles actually will start to return. They may have some tingling and numbness and some motor weakness as a result. So there's other multi-system effects you have to watch for, things like multi-system trauma, as I mentioned, from getting blasted, thrown. They may have various degrees of neuropathy that may actually last permanently. They may have pain syndromes as a result. You can imagine why somebody might have PTSD after something like this. And in some cases, they have ruptured tympanic membranes, their eardrum ruptures from blast effect. This is particularly true if they're on the phone in their home and the lightning comes through their phone that is a wired phone. They can become deaf, have CSF otorrhea. And the same thing goes with blindness. People have had traumatic cataracts develop, retinal detachment, and then these long-term neuro effects as a result. So even though somebody survives, more than 70% of survivors will have some sort of permanent disability. There are actually support groups for these people nationally, and they have at least some connection because with others who've experienced it, they may find that no one else can really understand what they went through, and the deficits may not be ones that people can readily see. So it is important that they have these support groups. Now, this is a victim of a lightning strike who came into my emergency department. This is a 16-year-old female. She was actually working with animals at a local zoo, and she was struck while she was out trying to get one of the animals to go inside. She was wearing a necklace, and you can see the charring and the superheated metal burns that occurred as a result. So that is, again, a clue if you're the one who arrives and the person is found down. This is her abdomen, but not the side view. Okay, that's a different person. But you can see, if you look at this picture really hard, you can see these feathering marks. They're known as coronographic, or again, corono, lightning. Graphic means record in Greek. So it's a lightning record, right? So
Feathering.
or feathering marks. And it's also known as erythematous arborization. Arbor, think of tree. These are not long-term types of marks. The gentleman next to her also had these marks, very pronounced, and this was shared with me by an emergency physician who took care of this patient. And these will actually dissipate within, an hour or two. So if you ever have the opportunity and the patient consents, you want to get a picture, because these are not going to be there for long, but they do tell you that there was the flashover of the lightning.
Really piercing.
What's that?
For belly piercing.
Oh, yes. And also Larry's reminding me that there is a little dot on the abdomen picture. That was actually a belly button piercing. And that piercing, that stud, became superheated and actually caused a skin burn. So belt buckles, anything that's metal that is overlying the skin can become super heated and cause a burn. So how do you care for these people? So the first thing is these patients are not electrically charged. So all of your standard interventions will work. However, you are at risk if you are still in the thunderstorm and you want to try to get this person into an enclosed vehicle or other shelter as soon as humanly possible because the whole rescue team is at risk. So CAB, CPR, AED, LMNOP, right? So all of the typical interventions, fracture stabilization, spinal motion restriction, trauma care, whatever is needed through your assessment. The burns are not a priority. They are typically not going to be severe burns. It's not like you're the victim of a electrical injury from AC current, like household current, where you've got an entrance and an exit wound. That's not that type of electrical situation. It's a flashover. Now, once patients get into the hospital, I realize I have some people on who may have they may be healthcare practitioners in clinical settings in the hospital. The cold pulseless extremity should not be looked at as, hey, this person might need a fasciotomy, which is literally where you're making incisions to open up the muscle compartment and allow that muscle to expand um, because of potentially compartment syndrome. It is not indicated, and this will typically resolve over several hours, and it may be sooner than later.
We, especially for, our patrollers right now, we're going through another refresher, including MCI management and triage. And when we deal with a mass casualty, typically if you have multiple patients, multiple injured, and when you get to that patient that may be pulseless, may be apneic, we pass on to take care of the ones that show signs of life. When we deal with mass casualties in a lightning strike, which is very common, especially in sports related fields, multiple people on a golf course, multiple people at a soccer game. Not so common in the US, but overseas, there have been cases, multiple people struck working in farm fields, where you have maybe 10, maybe a couple of dozen people struck at the same time and are down. Standard MCI triage principles don't go into effect. We're looking at what's called for lightning strikes, we're looking at reverse triage. So if somebody is showing signs of life, they're screaming, they're crying, they're moving around, they're up and walking around, you let them go for right now and go to the people who are down. If you have a couple of people down and lots of people making noise, go to the people who are down. If you can start cardiopulmonary resuscitation, if you can start rescue breathing on these people, you can possibly get a lot of them back because, as Linda said earlier, their respiratory center has been paralyzed temporarily. They may have pulses, they may not have pulses, but if you can support the respiration and support their cardiopulmonary status for several minutes to, a longer period of time, the heart's ability to restart itself may kick in. If you do not support their pulmonary status, if you do not give them rescue breathing, they will die because their heart is not getting any oxygen. So you go straight to those people who are down, continue CPR, get your AED, and do any advanced cardiac life support interventions in the hopes that they will restart on their own or with assistance.
Very often the patients who you're doing CPR on in this type of situation, they come back. And then you can still defibrillate, you know, all the standard protocols that you would use for defibrillation, it's still fine, even though they were struck and maybe they had, you know, the kind of the massive DC counter shock of the lightning strike or the current phenomenon. The AED or defibrillator will still work and is still indicated. So some prevention tips. You want to know weather forecasts. NOAA is a great source. And you're going to think about the location and the timing of your hikes. So if you're in Colorado, for example, this is a place we love to go. If you're going to go out hiking, you're going to summit by noon. You're going to be off by 2 p.m. Because you know that the thunderstorms are going to blow in after 2 p.m. and they can be pretty intense. And we've been there when they've been pretty intense.
Where we have not been off by 2.
No, no, still working our way down. So when you hear thunder, seek shelter. That's the bottom line. You're going to descend from high points and any ridge lines. And if you're in a group of people, you want to separate. You want people to be able to perform CPR on you is the bottom line. So you don't want to take everybody out in one fell swoop. So the recommendation is that people should be no closer than 20 feet apart. We actually had to separate in crossing an open area just to try to get into a big stand of trees, which I'll talk about in a moment, which is a little safer than being out in the open, obviously, or under just a couple of trees. If you're climbing, wet rope can conduct lightning. You want to also make sure that if you're out, you have no contact with metal objects like ski poles or axes or anything that might cause a contact burn. So there's something known as the 30-30 rule. That's the flash to bang. If it's less than 30 seconds, there is danger. And you want to shelter at least 30 minutes after the last thunder. Now, okay, so you look at this graph here and you see this line, which is exposure to risk. So it's kind of an interesting line. So the thunderstorm is approaching. And so the lightning risk is actually starting to go up. But your exposure is very high because oftentimes people think they still have time before they can get inside. So they're out in the open. So then when the thunderstorm is directly overhead, most people are sheltered in some way. And then when the thunderstorm is departing, that's when people think, oh, it's clearing up outside, I'll go out the door. But interesting, they still may be struck. And this is where actually they've got a fairly high risk because they are not in a shelter and the storm may not have moved far enough away that a bolt from the blue just can't take them out. So you definitely want to stay inside long enough after that storm ends. There are lightning detection apps or cell phone apps or devices.
A lot of your phones, the Weather Channel, NOAA, there are detection apps that you can have on your phone. Of course, keep in mind that this requires that your phone have an active signal. In some cases, there are items like Strike Alert. We're just using that because it's one of the common names of a detection instrumentation. And years ago, before cell phones became so popular, these were very popular for sports teams, coaches to have in their pocket. And they kind of they just monitored electrical activity in the atmosphere and would alert when they detected lightning strikes within miles of the location. I don't know how popular they are now. I think a lot of people have gone to the phone apps, but they're still potentially useful items for especially for large groups or people at risk if you're climbing mountains or, putting yourself in an area where lightning is frequent.
And you don't have a cell signal because that will still work. Yeah, okay. So in terms of what is substantial shelter, so the safest shelter would be a substantial building, enclosed metal top vehicles, so not the convertible where you've got that cloth top. should be a metal top vehicle. And sheds are not considered safe shelters. People have been struck in sheds. They're typically metal. Tents are certainly not safe. Shallow cave entrances are not safe. You don't want to be near any open doors or windows or fireplaces or metal objects. I talked about that. You want to get off the corded telephone and turn off any electrical appliances, mainly because you can also have those appliances damaged by the lightning. And I put the picture in of the woman with the metal necklace because if she is struck, you can bet that that metal necklace is going to be superheated and cause a burn around her throat. So if you have no shelter and you're outside, you can make some choices. There's not a lot of safe choices outside. However, don't stand under the tallest tree or object because we talked about it. Lightning will go to the highest point. If you have to make a choice, go to a dense stand of trees that are lower if you can, but at least a dense stand of trees, far better than standing out in the open.
Don't be the tallest object or near the tallest object in the area.
Absolutely. You want to get out of the water, and that includes the indoor bathtub or shower, and don't use the sink. And that's tough because you think, now how often does this happen? Well, I don't know. After I saw the picture of that toilet, I started rethinking a whole lot of choices. Anyway, so signs of an imminent strike. So your hair starts to stand on end. This is not a good sign. You can also see blue halos around objects, and that has a name, and it's called St. Elmo's fire. The picture below shows St. Elmo's fire on an airplane. Sometimes that will show up on an aircraft if you're sitting in the passenger seat and you look out and you sort of see this blue glow. It's not uncommon. It's static electricity. And again, if you're the one who's at risk, you may hear high-pitched or crackling noises. That St. Elmo's fire is plasma energy. There are articles about ball lightning. Some people believe in it, some people don't, but there is actually some scientific evidence to support the fact that there is this actual ball energy that can move through the house. You don't want to sit or lie flat on the ground. You want to minimize your contact um, so that in the case of a ground current or a ground strike or side flash, it's not taking out all of you. It might just be the lightning be contacting a very small part of you. So am I at risk here? Put it in the chat. Yes or no? Anybody?
Yes.
Yes.
From Pat.
Okay, Pat.
Yes, from John Leonard.
John and Pat, you're right. So entrances to caves and shallow caves are high risk for lightning strike. That surface to ground arcing can occur. You can sometimes see char marks in these caves from where lightning literally, came in. There have been some interesting case studies, some tragic ones of people who were climbers and they took to shallow caves and all lost their lives as a result of these types of strikes.
One of the risks of shallow caves is the rock can have fractures in it. The fractures get water in them, and the water's always there in small quantities. If that rock or mountain above that cave is struck by lightning, that water becomes a pathway for the electricity to travel. It gets to the top of the cave, and it's going to pass down through to the ground. So you almost become, now you're the tallest object in the cave, and the lightning finds a preferential pathway.
So am I at risk here? Anybody?
Yeah. Yes.
Absolutely. That was England, by the way. Larry, Ann, and I went to, we walked across the Lake District, did about 120 miles. It was
But we had
awesome.
no lightning.
Yeah, we had no lightning, but we would be at risk if we did. Okay, so yes, so
She's only 5 feet tall, but at that point she was the tallest object on the mountain.
so mountain peaks, high
That
points
doesn't happen often.
are quite high risk. So get off the high points. So do rubber-soled shoes offer protection? I know what I used to think when I was a kid running around with my Keds,
Only a little.
Keds sneakers, right? So are these, is this protective?
No,
No, right? They're not protective. Rubber soled shoes or boots have no protection as we think back to that boot that was steaming after that guy got struck by lightning.
Or metal tips.
Or metal
Right.
tips, right? Does your car offer protection?
yes.
Yes. Yes, absolutely. And the answer is yes. Vehicles can certainly be struck. It's not the rubber tires. It is the fact that it is fully enclosed. So if
Like
you
a,
pulled
it's like
over,
a Faraday cage.
It's a Faraday cage that the electricity travels around the outside of the vehicle to ground. And as long as you're in the car and not touching anything, you're relatively safe.
that also means though that you should not be touching items on your dashboard because your electrical system can short out, catch on fire. You also have to be very careful that if a tree or wires come down, you're not trying to get out of your car and you've got live wires down on your car, obviously. So there has never been a recorded fatality in a fully enclosed metal top vehicle purely from lightning. I'm not talking about the tree on top of the car. I'm just talking about the lightning itself. But there is an indirect lightning risk, right? So tree on car, and of course, all of the debris that can occur from the blast force of a tree being struck by lightning.
For those of you, spend a lot of time outdoors, the old method, if you were out by yourself, you're in the middle of nowhere, there's a lightning storm, and there's no place to shelter. They used to say, well, you take your pack off or you take your foam pad, put it on the ground, crouch down, so only your boots are in contact with the ground, and kind of go into almost a crouching fetal position. And that was the old method of trying to protect yourself. I think there is absolutely no definitive information that says that works. I think the only thing it does is it gives you something to think about and to do while you're waiting for the lightning storm to pass. But there's no evidence that it actually keeps you from getting struck, other than you're making yourself as small as possible.
So moving right into snakes, can we move into snakes? Is that okay, Eric? All right.
Yep, that's fine.
Okay. So let's talk about poisonous snakes. And Pennsylvania has poisonous snakes, and it's important that we know how to manage these. They are native to all states except Maine, Alaska, and Hawaii. And poisonous snakes bite, you can see 7,000 to 8,000 people every year in the US. So they produce relatively few deaths, however, and that is because of the antivenom and the advanced care that we have available to these folks. There were a lot more deaths than that in years past. So who is most likely to die? People who are elderly, children, people who don't get antivenom. And this is a really important point because with antivenom, there are still a number of people who believe that antivenom isn't needed. And I know some healthcare professionals who don't deal with wilderness medicine topics and don't know a lot about snake bite, but yeah, they didn't need antivenom. I hope to change everybody's mind about that by the end of this presentation because it is absolutely indicated in certain cases. If that antivenom is inadequate or late, and the snake bite related deaths do not usually occur right away. They usually occur 18 to 32 hours after the envenomation due to multisystem organ failure and other deleterious effects of the bite.
Now, just as a disclaimer, we're speaking strictly about the United States, Canada. There are snakes overseas that are much better than anything we have here. So we're strictly speaking about US snakes.
Yes, absolutely. Thank you for pointing that out. Yeah, there are some that will kill you within minutes. So,
There's a snake overseas that's known as the two-step because that's how many steps you take after you get bit.
before you die, yes. So risk factors, typical young adult males, typically older than 20, children less than 10, people involved in the rituals or sport, drugs and alcohol, and those that just see a snake and want to pick it up. Oh, look at this. And then they get bit and they wonder, what kind of snake is this? So this was a article in the newspaper here in Delaware. It was veteran snake handling pastor dies after the bite. That's actually a big thing. There are a lot of these churches that believe that they handle snakes, and if they are bit, if they are of the faith, then they're protected, and if they die, well, then they weren't of the faith. Well, apparently, not only did this guy die, but then a few years later, his son died as well also from snake bite, venomous snake bite, because they don't seek antivenom. So what kind of snakes do we have here? We have actually two types in the US. We have Crotalidae and Elapidae. The crotalids are the pit vipers, and the pit vipers are the rattlesnakes, the cottonmouths or water moccasins, and the copperheads. And in Pennsylvania, we have rattlesnakes and we have copperheads. If you're in the southern part of the US, the cottonmouths, the water moccasins, are much more common. So, how are the pit vipers recognized? They've got this foramen or pit between their eyes and each nostril, and these are heat, because they kind of can detect heat, and they will enable the snakes to locate that warm-blooded prey. And we'll show you a better picture of these. They also have a triangular head, and there's a really good example of that triangular head in this picture. And the reason the head is triangular is because of venom glands. And if you flip that snake over, which I don't advise, typically the single row of subcaudal scales indicate a venomous snake, a pit viper, but there are some exceptions. So I don't recommend that you're looking at subcaudal scales to identify a snake as being venomous or not. So this was a gentleman who taught us a snake bite class down in that was in Roanoke, I believe, or was that it might have been in North Carolina. That was in Black Mountain, North Carolina.
Yeah.
Anyway, we took a course where this gentleman came in and he brought his pit vipers with him, so we have some really good pictures from his pit viper demonstrations.
And he's been bit several times and is still there teaching. So
Yeah. So these the pit vipers, they have these two curved fangs that have canals in them through which the venom passes. And it's interesting, these fangs will retract back into the mouth when the mouth is closed. So they're like hinged. And you can't just defang a snake like you can declaw a cat and assume that the snake is no longer venomous, because there are replacement fangs behind the major fangs. So if one of those fangs comes out because like the prey doesn't want to be bit and it puts up a fight and the snake loses a tooth, a replacement fang will come in and then, be the next fang. And the snake can actually size up the prey and decide how much it's going to inject based on that prey size. And it can inject from either of the two fangs. So if you surprise the snake and you kind of come up upon it, it's anyone's guess how much venom is going to be, um, how much venom is going to be injected. So yeah, we'll be taking a break in just 1 second there, Eric, and we will give me 5 minutes and we'll go through some of the recognition. So venomous, so a triangular head, an elliptical pupil, and I don't recommend you getting too close to do a pupil check on the snake. The pit between the nostril and the eyes, and then the fangs, and also rattlesnakes, of course, have a rattle. Now, non-venomous snakes have more of a rounded head, like this little guy. They have a round pupil, not an elliptical pupil that looks kind of like a slit. They have no pit. They're not a pit viper, right? The pit would be right here. And they have no fangs or small teeth. So these non-venomous snakes, they're nice animals. They don't need to be killed just because you see one. They actually do a great service by killing rodents. We actually have one that lives in our wood pile. This is Jake the snake, and he really likes the garden hose. So
And there are also some non-venomous snakes that mimic venomous snakes. They take advantage of looking like they're, you know, venomous cousins and use that to their advantage. So in general, you try not to harass snakes, don't try to move them. They're there. Most of them are beneficial, even the venomous ones. And there are groups out there that if you have them close to your home and you want them relocated, there are people out there that will remove them and relocate them safely. So chopping their head off with a shovel is not necessary.
not at all, no. Just to go through the identification of some of these the venomous snakes. So here is the rattlesnake. And again, the coloration patterns can be highly variable depending on where you are and the different type of species of rattlesnake. But these are again some pictures that we took, and you can see the rattle at the end of that snake there. And if the rattle isn't there, but it looks like a rattlesnake, assume it's a rattlesnake because that snake's tail could have been lost in a fight with the prey. There are timber rattlesnakes. Again, this is an area we have timber rattlesnakes in our mountainous areas of Pennsylvania, near our ski areas, and you can kind of see this guy moving here. And you can see the elliptical pupil very, very nicely, and you can also see the pit in that pit viper. So the pit is, if I can show it, you can see it between the eye and the nose. That's the pit. Okay, so thank you for showing us your head there, Snakey. Actually, I don't mind snakes. I like snakes. The cottonmouth or water moccasin, which you won't encounter unless you're down in the southern parts of the United States, they have this white mouth. That's why they're called a cottonmouth. It looks like white cotton. This picture was taken by a friend of ours, a guy named Seth Hawkins, who's a physician. He was kayaking, and this water moccasin was actually chasing his kayak. And these are snakes that are very aggressive in the water. In fact, most snakes are aggressive in the water because you're moving and it sees you as prey and it goes after you. So that they're trying to get a fish or get some water-borne thing. Here's a copperhead. Copperheads are actually very beautiful snakes. The copperheads of all of the venomous crotalids that I was showing you have the least toxic venom. The most toxic is the eastern diamondback rattlesnake. And the eastern diamondbacks are on the East Coast. These copperheads, again, they're frequently found in Pennsylvania. They are found in Delaware. They're smaller snakes. They tend to be shy and they tend to hide, but you can put your hands or your feet, in areas where there are copperheads. So, and they can pose a pretty venomous bite. So why don't we stop here? And Eric, when would you like everyone to come back on?
It's here. It's 8:04, so let's take a 10-minute break and be back at 8:15.
Okay.
Sounds good.
All right, we're gonna get started again. So it's all yours, Linda.
Okay, thanks so much. So we talked about identifying venomous snakes. So just a little bit about venom composition. There's really two main reasons why snakes and venom, and what they're trying to do is they're trying to immobilize and they're trying to kill their prey. And they can do that in a variety of ways. And every snake's venom is a little bit different. And it depends on the species of snake. And I'm still talking about US, North America, crotalids, the rattlesnakes, copperheads, and water moccasins. But if you were to analyze that venom, there are substances in it that clot blood, that unclot blood, that cause massive bleeding. There are neurotoxins. There are hemotoxins, blood toxins, in other words, cardiotoxins that affect the heart. And so you can have all manner of different types of effects on the body as a result. So when we look at a patient who's had an envenomation, there are a number of factors to consider. One is potentially the size of the snake, because larger snakes can inject more venom. Snakes, however, venomous snakes are venomous from birth. It's just that they only can inject a small amount of venom if they're really tiny. Now, the potency of the injected venom can also vary. So, for example, if you're traveling out west and you're in the Mojave Desert, there tends to be the Mojave rattlesnake, right, in that area. So, if you were to be bit by that snake, you would have more neurotoxic effects than you would if you were bitten by a timber rattlesnake in the Poconos. Again, it just depends on what is in the venom. How deep was the envenomation and where was it? So if the person bites a highly vascular area like the face or the neck, you can have immediate crisis. And we did have a patient in my ED where that indeed happened. And I will be showing you a picture of him. And he went into a pretty immediate cardiac arrest as a result of that, because you just get this massive venom load. So also the number of strikes. Snakes can strike more than once. If you're still in their area, they can continue to bite you, and they can still continue to inject venom. They will start to deplete their venom. It's certainly not this unlimited supply, but you can be envenomed multiple times. And if you have a small person or you have a person who doesn't have good health, all of these things can make the envenomation worse. So we can look at a person's extremity or area of the bite and kind of get a sense of whether or not no envenomation occurred, or minimal or moderate or severe. So in no envenomation, here is where the snake bit you, but it didn't actually inject anything. And about a quarter of bites are actually dry. Meaning you surprised the snake, and the snake bit you, but never thought to inject anything, or perhaps it had just bitten something, expelled most of its venom, and now it's a dry bite. Uh, and you'll have fang marks, but that's about as far as it goes. You'll just have, like a little local reaction without a systemic reaction. A minimal envenomation, here you have the fang marks, but now you start to see evidence of contusion. So there's some, bleeding into that skin, that tissue. You're looking at bruising. The patient may complain of a strange taste in their mouth that is often described as rubbery or minty or metallic. But yet at this point, with a minimal envenomation, they're not having really major toxic effects at this point. However, these envenomations can evolve. So you can start in looking like maybe it's a dry bite, but over the course of a couple of hours, these envenomations can worsen if more venom has actually gone in. So in a moderate envenomation, now you have fang marks and you've got both local and systemic effects, so body-wide effects. So people complain of severe pain. They have nausea. They may have vomiting, paresthesias, which is that, tingling and numbness. Their muscles can fasciculate or quiver. They can have a lot of swelling, and not just at the bite site, but well beyond the bite site. So the entire extremity or area of bite starts to swell. Now, coagulopathy means that your blood is not clotting normally. And in moderate envenomation, if they have any areas that are open cuts, wounds, or even the bite site itself, they can bleed from that, but it's just mild at this point. But in a severe envenomation, now you've got fang marks and you've got these severe swelling, and the local response is severe, and now people are really critically ill. They may be hypotensive, so low blood pressure. They may have seizures, and here is where they are bleeding. I mean, it's like the audible bleeding. They are bleeding a lot, and they can be bleeding from even some older wounds that haven't quite healed. So here is an example of moderate to severe envenomation. So they get hemorrhagic bullae. So all of these areas weren't necessarily, the actual bite site. The bite site could have been, in one area, but you bleed into the tissue from that coagulopathy, that bleeding issue, and you have these terrible hemorrhagic bullae that develop as a result, these big blood blisters. So this was our patient in the emergency department where I worked, and he had a pet eastern diamondback rattlesnake. And one evening he drank too much and decided he wanted his snake to kiss him on the face, and the snake did, and it actually bit his cheek, and his face swelled up like this. I saw him before and after. He did survive this, but he went into cardiac arrest. The other problem was he had a previous bite, and he had an allergic reaction to the venom. So not only did he have a reaction to the venom that was toxic from the venom itself, he had developed an allergy to the venom. So he went into this massive anaphylactic reaction. He also was a body piercer and a tattoo artist, so he had the little bars in his tongue, and he had just tons and tons of jewelry, of piercings all over his body. The bar in his tongue was bleeding, even though it had healed long ago. And so he was very difficult intubation, ultimately needed a surgical airway. So you can see that he has this was actually a formal tracheostomy, not a cricothyrotomy. So he's getting ventilated that way. This was a day later in the intensive care unit. He still has a lot of facial swelling, and you can see.
John says you can't fix stupidity.
No, no, you can't. And then there these little items that you see on the chest X-ray. These are nipple piercings. He was bleeding from those too. It was just quite the event. So he wound up taking 46 vials of antivenom. We went through our supply completely and had to go to the Philadelphia Zoo to get more. And my point here is that if a hospital runs out of antivenom, they typically do have to go to some place that has a herpetology area, and zoos are very common suppliers of more antivenom. Okay. So what do we do with a snake bite? There's not a lot you can do in the pre-hospital arena except recognize the severity. You've got to move the person away from the snake because you don't want to get bit and you don't want the person to get bit again. You do not have to kill the snake. You want to manage the person's ABCs and do whatever BLS or ALS care is appropriate for whatever they're manifesting at the time. They may need an airway. They may be managing their own airway and not having a lot of symptoms initially. You want to advise rest. The more that person jumps around because they're freaking out, the more they will have a venom effect. It will speed the venom. And you want to get any tight clothing or jewelry off of them because they will swell. And here is one of the areas that is very, very controversial. Now, from all that we have read and learned and talked to people who we have a lot of friends who are kind of in this business of toxinology, believe it or not, it's keeping the bitten extremity at or above the heart level. There used to be advice, particularly in the pre-hospital area, to keep the extremity lower than the heart to prevent the venom from coming up out of the extremity. Well, that has sort of been debunked. So the idea is the swelling is going to be profound and the venom is already circulating. So keeping the extremity low is not helpful.
It's going to keep the hemotoxins in the extremity more, which is going to cause more hemotoxic effects in the extremity. It's already circulating, and keeping the extremity low isn't going to keep it from circulating. So elevate it at or above the heart level.
So there are some sources that say only do it above, and there are some sources that say at. So we just said at or above, and it kind of comes down to what your protocol says. But if it says below the heart level, that needs to be updated. And you want to transport as soon as possible. Now, go ahead.
Do not bring the snake to the hospital. Everybody has a cell phone. Everybody's got a camera. If you can take a picture of it but the hospital does not want the snake in a bucket. It does not want the snake in a bag. It does not want the head of the snake. Just leave the snake where it is, take a picture if you can, and take the patient to the hospital.
Absolutely. So we do not apply ice. We do not apply a tourniquet. We do not incise and suck the wound like you see on the John Wayne movies, right? Um, as Larry talked about not capturing or handling the snake in any way. Uh, the thing about snakes, in the event someone stupidly has decapitated the snake, don't try to pick up the head, because even a decapitated head of a snake can still inflict a bite. Believe it or not, the biting reflex is primitive and it actually lives longer than the snake does. So it's not one of those things where if the snake's been dead a really long time, it's still going to potentially bite you and envenom you. But certainly within a couple of hours, that bite reflex can still be there. We know an individual from Texas who told a story of how a guy got bit in the woods. A bunch of his buddies threw him in the back of a pickup truck, cut the head off the snake, threw the snake in, and the head actually wound up biting the patient a couple more times in his travels to the local emergency department.
Linda also had a friend whose husband was bitten, and I guess he was bitten again by the decapitated snake.
Mm-hmm.
The last one there, don't use the extractor devices. Your camping supply stores have these wonderful suction devices that have shown no efficacy in extracting poison, and it can actually do local trauma to the bite wound.
They don't work. Bottom line, they don't work. So in terms of advanced interventions, all right, so let me just actually put something out here right now. There are people who believe, oh, I've got to get the snake identified. If there are one or two fang marks, and the person looks like they're envenomed, and you're in the US, and they weren't keeping some exotic in their house, and this thing was, in the general environment, it is either a rattlesnake, a copperhead, or if you're down south, it could also be a cottonmouth. The anti-venom is the same for all of them. So it doesn't matter. You don't need a subspecies for this. It helps to have a picture, potentially. That way the guy can get a publication out of it, right? Whoever's but really, it's more about what the patient looks like, and you can draw the conclusion that this person was bitten by a venomous, typically again a crotalid. I'll cover the coral snake just very briefly as soon as we're done here. So advanced interventions. So what happens? So they get to the hospital. They will contact poison control for support in terms of, the type of antivenom. And really, there's only two types of antivenom. There's Crofab or Antivip. And they are both, it just depends on whichever one the hospital buys. They both do the same thing. Antivip is a new antivenom of the last few years. Crofab's been around for a while. It is a sheep-derived antivenom. The Antivip, I believe, is an equine-derived antivenom, and they work very well. It can take multiple doses depending on the amount of venom. Children actually get the same dose of antivenom as an adult, because the way antivenom works is it binds to the toxins that are injected. And so, really it doesn't matter. Like pediatric dosing wouldn't make sense, because if they get a big venom load, then you still have to give them a big dose of the antivenom in order to bind the venom that was injected. These are tetanus-prone wounds, so they do need tetanus prophylaxis, tetanus immunization, wound care. They don't typically need antibiotics. And just a couple things for those who may be working in the hospital. These people need EKGs because there are cardiac effects. They need a complete blood count, coagulation profile. They will bleed. They're very, very high risk for bleeding. And they may need x-rays or imaging to detect any potential retained fang or tooth in the wound. It is possible, but it's extremely rare. And for these extremities that just really blow up, There may be those surgeons who are just waiting with the knife to open up the muscle compartment. It's called a fasciotomy. But typically, if you give sufficient amounts of antivenom, you don't need to do the fasciotomy. So all that is not indicated, and typically blood transfusion is not indicated. What patients need is antivenom and adequate dosing. So just for your knowledge,
NSS?
Yeah.
For if you're really interested in snakebite management, there is a site on Facebook called National Snakebite Support. It is a group of physicians, I think there's some nurses and some veterinarians who are experts in the field of snakebite management. They have their page. People can contact them through Facebook and ask questions. My dog was bitten. My son was bitten. We're at the hospital. They don't want to give antivenom. What do we do? They have their experts who will come on and tell you. They have guidelines for both human envenomation and animal envenomation. They are extremely timely. They actually have physicians who are treating patients who will contact them and ask about the proper treatment if they're in an area where they don't see a lot of snake bite. Just as a disclaimer and a warning, if you join their page, make sure you read their guidelines. Somebody can ask a question. Only the experts from National Snakebite Support can answer. Nobody else can comment on those, on the particular case they're talking about. If you comment, you will be disappeared from their page. Only the person posing the question or the case and the experts with National Snakebite. But if you read through, you can get a lot out of the treatment of both of snakebite for both human and animal envenomation.
They have guidelines. They have pictures. It is a really excellent site. So highly recommend it if you have an interest in this area or spend a lot of time in areas that have snakes. Just a couple slides on coral snakes, and I only throw this in to be complete. This is the other variety of venomous snake in the United States. And the information that we're giving you is only for the US because there are snakes that look like coral snakes in other countries that may have a completely different type of profile and a completely different kind of venom. So if you are in the Gulf regions, if you're in the South, that's where you're going to find these coral snakes. Some people may have them as pets. I don't know why, because they're pretty dangerous. But you recognize them with the typical mnemonic, red on yellow, kill a fellow. So you can see the coral snake, the red and the yellow bands are touching. And the next picture over, the red on black, venom lack. It's not always true. It's sort of one of those general kind of rules of thumb. If it's red and black and yellow, I'm not touching it. But when the yellow band, excuse me, the red band is not directly touching the yellow, and there's that black band in between. These are
generally
not venomous. They're king snakes can look like that. They can be a mimic. But these are kind of a different snake. They have very, very small fangs. They're generally very non-aggressive. Children tend to pick them up because they're pretty. They have these non-retractable fangs and small teeth, and they chew their venom into the patient, and then that venom is spread by the lymphatic system. And whereas the crotalids that I just went over have these really painful, horrible wounds, and they produce these massive extremity injuries, that a lot of edema. These are neurotoxic types of bites and myotoxins. So what happens is over the course of hours, people can develop difficulty breathing. They may stop breathing. They may need to have ventilatory support, on a ventilator for days on end until the the toxin is you know, absorbed and neutralized. Myotoxins, they can develop various types of paralysis. So prolonged observation in a hospital setting are typically indicated. There is an antivenom. For the longest time, we did not have an antivenom that was made here in the United States. In fact, I believe the antivenom that we have now, you know, it was originally produced in Mexico. I believe it is now being produced in the US as well. Again, these are not common bites, but when they happen, they're very serious bites. So here again, maintain that bitten extremity at the heart level, and they typically do need that antivenom. But one of the things that you can see in these patients, they wind up getting what's known as ptosis. Ptosis. Ptosis means your lid is drooping. We have a friend in Florida. He's a physician. He sees and treats a number of people in the Florida area who are bitten by coral snakes. And he said what he looks for immediately is if the eyelid is drooping, he knows for a fact they've been envenomed. And then, you know, he starts the treatment from there. But you get a lot of the neurologic effects, as you can see. So just some general common sense things about snakes. Don't molest the snakes, use common sense. Don't keep the venomous snakes as pets and stay at a striking distance and out of the snake infested areas or anywhere that you're going to put your hands and feet where your eyes can't see. Boots and protective clothing are very helpful. In fact, there was a study done on wearing blue jeans, and the heavy denim blue jeans actually do offer protection against, you know, a strike of a snake to prevent envenomation. And then there's the bite that Larry had in our backyard. This is Larry's hand. So one day,
Cutting the grass, found a just a non-venomous garter snake tangled up in the blueberry netting. I like snakes. I went to cut it out of the blueberry netting to set it free. And as soon as I cut part of it away, it latched onto my finger. And I thought, it's a garter snake, no big deal. Just held it up and continued cutting away the blueberry netting, and took 5 or 10 minutes, and finally let the snake go. And finished cutting the grass, came inside, got cleaned up. And by the time we called the doctor, my arm was swollen up to the elbow. And by the time we got some antibiotics because it was right over a joint space, my arm was swollen up to my shoulder. And Linda got an article written in the Wilderness Medicine magazine about it because it was unusual, but it was a non-venomous snake bite, but they do have a primitive venom. And if you let them gnaw on you long enough, you can get envenomated.
I had I keep odd articles. So I had 2 articles. Both were case reports of the eastern garter snake, which is what bit him. And the eastern garter snake has this primitive venom, as Larry said, in its saliva. And normally, if it bites you, it's not a big deal. But if it is attached for a prolonged period of time, it can cause a primitive venom reaction. Now, there's no antivenom that's needed for this. And normally you wouldn't even give antibiotics, but he was using, he had his hands in the mulch. And so when I came home from work,
It was a very dirty wound.
it was an extremely dirty wound, and I didn't want him to get a joint space infection. So we went with the antibiotics, and the doc had a good laugh about the whole thing. And eventually, over the course of a couple days, his arm went back down to normal. But you can actually get envenomed. The last thing I want to cover today, and we certainly have a lot of other things that we can talk about in the future, but I think Lyme disease, and if I can get to mosquitoes, I'll get to mosquitoes, but I want to focus on this and tick-borne illness in general because it is so prevalent. So, quiz, which image represents Lyme disease? Anyone? Or images, I should say.
Deer tick.
The deer tick, okay. Sorry, say
Tick.
again?
Tick, tick. tick. Yep, we got ticks.
Ticks. Okay, ticks, yes. And actually the state of Connecticut as well. So why do we have the state of Connecticut on there? So because that is where Lyme disease was actually discovered. And we now know that it's a lot it's in a lot more places than Connecticut. So it is the most common tick-borne illness in the US. And as of 2023, the CDC had confirmed over 89,000 cases. We are in a very tick endemic area in Pennsylvania, in Delaware. You can see Maryland, Delaware, Pennsylvania, very high risk. And the highest risk times of year are April through October. However, because of the warmer winters, the ticks are not actually dying, and they're diagnosing cases, even in like January and February, where you would not expect to find a case of Lyme disease. So the ticks are still out there. So as I mentioned, Lyme disease was discovered in Lyme, Connecticut. And what happened was children were playing in a playground and in the woods, and they all were developing these strange cases of juvenile rheumatoid arthritis. And they had this very strange circular rash at the bite site, which has come to be known as the bullseye rash. And so it wasn't until 1981 that scientists learned that this was caused by the bacteria called Borrelia burgdorferi, and it is transmitted via the black-legged tick, otherwise known as the deer tick. And these black-legged ticks are now across the U.S. So both the adult ticks and the nymphs, or these very tiny little immature ticks, can transmit Lyme. And in fact, the nymphs you can barely see. And so most cases are transmitted by nymphs because you simply don't know you have a tick on you. So here are some examples of the black-legged tick and just how small it actually is, the one in comparison to a dime. And I have pictures of deer here because the deer they harbor these deer ticks. However, there are certainly other animals that harbor them as well. I actually heard someone say once, well, we'll just get rid of the deer and that'll take care of the ticks. Well, no, it won't, because these deer ticks are also on mice. They're on many, many other woodland animals. It's just, the deer became kind of the ones that have been most known for them, but others. So signs and symptoms. So in the early phase, you can get that circular rash, and I've got a picture I can show you in just a second. And it is this sort of reddened outer rash and a clear or lighter colored center, and that is known as erythema migrans or the bullseye rash. So the CDC said that to confirm that that is indeed a bullseye rash, it's got to be at least 2 inches in diameter for diagnosis. And it doesn't always occur in all patients. It's only occurring in about 50% of patients. But in that early phase, people have these flu-like symptoms where they're complaining of fever and headache and fatigue, and the joint stiffness and the muscle pain can be really, really severe. A friend of mine had this, and she's another nurse I used to work with, and she talked about waking up and just feeling as if every muscle and bone in her body hurt, and she was literally crawling across the floor, wound up calling an ambulance, and was diagnosed with Lyme. There's the early disseminated phase, and this can be over weeks to months. And here is where you start to see those facial droops. So again, another nurse friend came into our trauma office one time and her face was drooping. She looked like she was having a stroke. And of course, she got worked up for a stroke. But facial palsy is a very, very common sign of later Lyme. It's still considered early disseminated. But these are folks who, again, still may have that flu-like symptoms. They can have poor balance, and they can have cardiac effects. So yet another friend,
Don't be her friend, whatever you do. Don't.
a mutual friend of both of ours, a surgeon, he was sitting in our trauma conference and he was feeling lightheaded. He happened to take his pulse, and his pulse was 20. So that got his attention. A heart rate of 20 is certainly not a good thing. Walked himself over to the emergency department, and the ED doc had figured out that this was probably Lyme. I mean, at this point, they're ready to pace him. He was a triathlete, mountaineer. I mean, the guy was very, very fit. His normal heart rate probably was 40. So he was tolerating 20 without the need for intervention with decent vital signs. But he needed to be treated. And once he had the antibiotics in, his cardiac conduction abnormalities actually resolved. You can also have late stage Lyme. This is a terrible thing. You have a permanent type of arthritis. This can happen over, months to years, joint swelling. Some people take long-term antibiotics. Some will say that it helps them. Some have just, looked for a cure, and yet they haven't necessarily found it. Here is erythema migrans, that bullseye rash. And you can see that there's that central area that is kind of a clearer area, but this is a very distinctive case of a bullseye rash. Okay, so the diagnostic piece, I just want to mention a couple things about this. There are two tests that they use for diagnosing Lyme. One is the ELISA, one is the Western blot. So not going to get into all the details here, except to say that positive means that both tests are positive. However, even in a case of real Lyme, not all tests will come out positive. So the sensitivity is still not high. There are some better tests that are under development right now. The goal is using clinical judgment to make a diagnosis and to treat. So there is a post-exposure prophylaxis. That's what PEP means, post-exposure prophylaxis. So if you know that a tick has bitten you, and some people will say the tick has to be on you for, 72 to 96 hours. And unless the tick feeds a while, you don't need this. However, there are other tick-borne illnesses that they only need minutes before they actually transmit disease. So for Lyme, and this also works for some of the other tick-borne illnesses, a dose of doxycycline, 200 milligrams, one time within that 72 hours of the tick bite is the post-exposure prophylaxis, and it's got a very good cure rate or prevention rate of developing Lyme. If people don't catch it right away, they can be put on an antibiotic regimen with doxycycline, amoxicillin, or cefuroxime or Ceftin. And then in the later stages, or if there's neurologic symptoms, they will actually put a PICC line in, and a person has to take IV antibiotics, the ceftriaxone. And each of these treatment regimens has to be individualized depending on what you're showing, what your antibiotic sensitivities are, what's effective for you. But that Doxy, 200 milligrams, I mean, that is a good drug. And if people can take Doxy, then and they are quite certain they were bit by a tick, that is the one. So prevention is key, and this is really where I want to spend some time. Protective clothing and insect repellents are absolutely essential. And actually doing a tick check, it can be fun if you have the right partner. And so you can use a mirror on yourself, or a magnifying glass if you're trying to see if there's a little tiny nymph tick on you. And in terms of tick removal, if you find that tick, how you remove it is important. You don't want to, I've heard, use a match and burn it. No, no. What you don't want the tick to do is to regurgitate back into the bite site, because that's where you're going to get the Borrelia transmitted. So the idea is that you take these tweezers, and they're little tiny tick tweezers you can buy, grasp that tick as close to the skin as possible, and with a steady pull, just pull it out until it lets go. And you can throw the tick in like 70% isopropyl alcohol, wash the area really well with soap and water, and then monitor for signs of Lyme disease. So there used to be a vaccine for Lyme disease as of like 2002. Anybody who had that vaccine in the past, it's no longer, you can't get it anymore and you're no longer protected. But there is a new vaccine on the horizon because there's just so many cases of this. And dogs and cats can get Lyme. They can't transmit it to you, and people can't transmit it to you, only the ticks. But pets will carry the ticks into your home and use tick control measures. You know, if the cat or dog needs, you know, a collar, or they have, there are oral medications as well, uh, or the substance that can be rubbed into their skin to kill these things, so that you can prevent the, you know, the Lyme disease. And if you throw your clothes that you were wearing outdoors into a dryer in high heat, that can also kill the ticks that may be attached to clothing, because you can also bring them into the house on your clothing.
The prevention of tick-borne illness is really important, especially, I mean, for this audience, your EMTs, paramedics, ski patrollers, in addition to just being outside, there's probably a lot of you that are members of search and rescue teams, spend a lot more time deep in the woods. You're going places, you're going off trail, being able to protect yourself with either chemical treatments or chemically treated clothing is very important.
And we're going to show you some of those. There is a new tick threat that I do want to cover, and that is something known as the alpha-gal allergy. Now, I don't know how many of you have heard of alpha-gal or potentially even have alpha-gal, but this is a rapidly increasing allergy. It is transmitted by both the Lone Star tick, which is the common dog tick, and the black-legged tick or deer tick, right? It causes a mammalian meat allergy. All this began in North Carolina, and then it has just spread, and it is in our area. In 2025, it is estimated there are over 450,000 cases of people who now have alpha-gal. So what this means is that you have an allergy to red meat and animal products that are found in beef, pork, lamb, venison, and rabbit. So you're thinking, oh, I'm a vegetarian, I'm a vegan. Probably not. However, medications often have components that were animal derived.
Gelatin.
Gelatin, yes. So the one picture is just the areas, you know, in this part of the world, but the western black-legged tick also transmitted, and it is out in the western states and into California. This allergy is potentially life-threatening. So on an EMS squad, you may get called for the sick person, the person having an allergic reaction. And what typically happens is people consume some mammalian animal product. They will then, within 2 to 6 hours after eating, it's not usually immediate, they develop hives, nausea, stomach pain, diarrhea, face and airway edema, and they can have full-blown anaphylaxis, and it can be life-threatening. They need to be managed by an allergist. They've got to have strict dietary avoidance of any meat product, or they can, again, go into this situation. They will need an epinephrine autoinjector, or the new epinephrine. It's Neffy, it's the nasal epinephrine, and the other allergy drugs. At this point in time, it's still not clear whether or not a person will actually need or will have lifelong problems, you know, with alpha-gal. Will they ever be able to eat animal products again? That's it, it's still too new, and people don't know the answer to that question. You may wind up being a vegan, vegetarian. Actually, even dairy will cause a problem, because dairy comes from animals, right? Beef. Or cows, and so it's everything that is produced, including butter, any animal derived product. You can eat chicken, you can eat fish. That's about it. I do want to get to prevention. I realized I didn't have mosquitoes in here, and just to mention, mosquito-borne illness is also just as bad. And I'm going to throw this in very quickly because the prevention is the same. mosquitoes cause a lot of disease in the world, and here in the United States as well. And the idea here is don't get bitten, and think about when mosquitoes are most active, dusk and dawn. And we're going to talk about the right clothing, the chemical repellents, and here we go. So this is going to be the last part of the presentation. We want you to take this with you. So permethrin. Permethrin is what can be impregnated into clothing. You can buy clothing that is already impregnated with permethrin. It is marketed as insect shield, and there's another one. Can't as you're thinking about it.
Yeah.
Yeah. So it is an insecticide. It is not a repellent. It's very low toxicity in mammals. You're not putting it on your skin, but you are putting it on your clothing. You can actually get cans or bottles of it that you can spray onto your clothing if you don't buy the clothing that's already got it in there. If you buy the clothing, it's good for like 80 washings. Now, with the bottle and the spray, it might be like 3 to 5 washings.
3 to 5 washings, or about 6 weeks of sitting around.
So you can put this in your tent and on your mosquito nets, and again you can wear it on your body. Now DEET is the other one. DEET is the gold standard. They've done studies on this with the military in intense biting conditions, and there is nothing better than DEET. You would apply this on your skin, not on your clothing, and you'll get a good 4 to 8 hours of protection. And you can use higher concentrations. They are available if you're in a malaria endemic area, like if you're on some African safari. So the combination of both DEET and the permethrin is best. There are a couple of other types of products that are insect, they're preventatives, is picaridin and eucalyptus. They are close to efficacy of DEET. DEET is still the best, although some people just think it's just too toxic and they would rather use something else. So picaridin is a good one. And eucalyptus isn't bad, but it still in the research doesn't have the same efficacy. So the idea is wear the clothing, use the spray on the parts of your body that's not covered in the clothing. And
with the chemical treatments, with the DEET, the picaridin, and eucalyptus, you treat them like sunscreen. That they're great for 4 to 8 hours, but if you're sweating a lot, if you get wet, you have to reapply because it will wash off or it will dilute.
okay, so I am going to stop share and take questions. So let's see. Hopefully tonight you picked up some things that you didn't know, and I
Can
appreciate
put
it.
questions in chat or unmute and
Yeah.
So good, they're speechless.
EMTs and ski patrollers, never.
So
Uh,
what was new tonight that was kind of an interesting fact? I guess I'm going to throw out a question.
Alpha gal.
Alpha gal. Yeah, it is a new thing. A lot of people don't know about it, but I guess it's been around now for 7 or 8 years, but it was thought to be something that wasn't real common, and now it's just exploded. They're trying to make sure that the emergency physicians and nurses know about this syndrome because it is so frequent, and that delayed presentation of the allergy symptoms is kind of what should make you think, okay, what did you have for dinner tonight? And they literally have to do a sort of a food diary and figure out what's causing it, and it's kind of a process of elimination. There is a blood test now for alpha gal, though. They can actually identify the actual antibodies to alpha gal in your system. So
Another alpha gal. A lot of information on lightning. wondering why Maine is a state without venomous snakes,
So
not Vermont or New Hampshire.
So that is a really interesting question. I've wondered that myself. But yeah, Maine, they do not have any of their own indigenous snakes. Now, that doesn't mean that someone can't carry one in there, and keep it as a pet. Um, it must be their microclimate. It's not hospitable to snakes. I think there must be border patrol that are keeping them out. I don't know. It's one of those weird things. Like you can understand why Alaska, and Hawaii don't have them, but Maine is an interesting one. I guarantee.
Lightning, the shallow caves figured better than nothing.
Hmm.
Depending on where you are, I mean, a shallow cave might be better than nothing, but you just have to keep in mind, you do a little risk assessment and you realize that there is still a risk. You're not perfectly safe or completely safe in a shallow cave, although it still might be a better option than being out in the open. But you have to make that choice. Some of the details about lightning. Any
Linda,
Yes.
it's funny when you mentioned the lightning because I just read an article yesterday that in September of this year there was 5 lightning deaths in the U.S. and they said that was the most they've seen since 2013.
Yeah. Yeah.
Okay, Pat, did they say where they were located?
I don't know if that was in the article or not.
I seem to recall last year there were a number on Florida beaches,
Hmm.
and they were just thunderstorms that popped up, surprising. People hung out on the beach but they were like a week apart.
Yeah, they had one here in Washington County, Wisconsin, they mentioned. So they were all a couple different areas.
Any time frame for the new Lyme disease vaccine?
And no, however, I think it's not going to be long because they're in clinical trials right now and they're pretty far along, so they should be ready soon.
Another question. Interesting triage for electrical strikes will need approval from NSP to be included in training. I'm not sure that reverse triage is not already in the OEC book. I'd have to go look at that. But reverse triage has been considered, kind of the standard
Standard
for multiple lightning strikes for some time, and I'm pretty sure it's probably in the OEC manual.
Yeah, that particular mechanism of injury, I mean, if you don't go to those people who are down first, there is no chance they're going to come back. And those who are up moving around, they're going to be fine. I mean, they might still have some effects of lightning, not to say that they might not have a disability as a result, but you getting to them before you get to the person on the ground is not going to help them in any way, shape, or form. It's
Apparently lightning strikes 3 in New Jersey this year, 1 on a golf course, 2 on the beach. It's not uncommon.
the Boy Scout camp. There was several years ago.
Yeah.
There was a large number of children that were struck and killed. And I'm trying to remember what camp that was. It's the big Boy Scout Jamboree area.
Oh, when it was down at AP Hill.
Uh-huh.
When it was down at Fort AP Hill, that was about 20 years ago.
Right. It was a mass casualty event.
And Terry says July 2025, New Jersey, 1 dead, 13 injured in an archery outing. I've seen some good, use the term good videos online of soccer stadiums. You don't really see the lightning strike. You see a bunch of guys playing soccer, and there's just sort of this little flash, and like 12 people just drop to the ground. It's incredible to see it happen, but it gives you an idea of what lightning can do at a mass outing.
Oftentimes you'll see char marks on the ground where people go down after they're struck. It really is a dramatic kind of situation. One thing I didn't mention, and this is just one of those interesting factoids, if you have fruit outside or vegetables, lightning can flash over and you will actually see that that ferning marking on your fruit or vegetables, so in your garden. And if lightning strikes on the beach, the sand actually superheats and forms these rock-like structures called fulgurites. And they're like these little, they almost look like coral, but they are tubular structures that literally come from the superheated
Molten
sand. Yeah.
There's the other video that haven't seen it for a while, but it was, I think we have it somewhere. And it was a security camera, and apparently it was a young man whose goal was to mug some passing bystanders, and they have him following this young couple that went down the sidewalk, and lightning strikes him, leaves a burn mark on the sidewalk. Guy goes down, lays there for a few minutes, comes to, shakes his head, gets up, takes a few more steps, and a second lightning bolt takes him to the ground. I think he gave up mugging that night. He did survive, but
Yeah, I mean, it was an incredible video.
Karma.
Definitely.
I think we'll answer one or two more questions if anybody has any. All right, I guess not. Thank you, Linda and Larry, for an excellent presentation. Thank you all for attending, and we will have another one out soon. So
Thank you for joining us.
Thank you very much. Really appreciate it.
Thanks, Linda. Thanks, Larry.